So let me see, Zoom, Telegram.
Oh,
Deixa eu ver.
wow.
There you
Perfect.
are.
Done?
Yes.
Perfect.
Perfect.
Yeah. I love Mac, but sometimes they make me nervous.
Okay.
So basically, what I'm talking about this patient was quite funny as usual in medicine. Carlos was asking if somebody could present a patient. So this, and I talked to one of my friends. Also, he's a vascular surgeon, and we did a similar patient, not like this, like 3 years ago. And I said, like, let's present this. It's a different approach. Let's talk. And then next week, and this is what we have. So this is a different vascular approach for vascular damage. So it was a pelvic gunshot. So I am Maria Detanico. I'm from South Brazil. I am a SBITE director from Rio Grande do Sul, and I work as a trauma surgeon in my hospital, that is Hospital Cristo Redentor. Let's see, vamos ver se vai passar. Não vai passar. Adoro isso.
Well, worked.
So yeah, it worked. So the history was a shooting from a soccer stadium. So basically the same, like the guy just come and shooting. Yeah. It was not related to the teams, the football team, but it was related with drug dealers and all the rest. So we have at that moment 4 person injured, and just 2 patients was sent to the hospital and admitted to the hospital. They was sent to my hospital. So this one was a male, 19 years. So he arrived more or less at 20 minutes after shooting. He had 1 gunshot wound and entrance more or less in the major trochanter of the left femur with no exit. So the physical exam was blood pressure was 85 by 50. The heart rate was not high, it was 75. We did the fast, it was positive. He already has a major peritoneal signs and urinary and rectal bleeding. So this was pretty much everything occurring at the same time, because when they arrived at the hospital, they called the surgeon at the trauma surgeon team. And then what he had, it was the antibiotics, the massive transfusion protocol that for us here it's total blood, and then one plasma and fresh frozen plasma, and 1 blood unit, and also tranexamic acid. This is what he received, and it was decided to the surgery and go to OT. So what we only did, it was some X-rays. So basically was this. So we have like here, if you can see, it was not pretty much good, but it was here, the entrance, and then it was crossed, but with no exit. So it was the first, and X-ray, thorax X-ray was okay. He had also some injuries in the hand, but it was nothing that we're gonna talk today. It was pretty much okay. So what we saw in the surgery was crossing the bladder injury. I really close to the bladder trigon. I put this because I could not find the definition. So up to you guys if it's really this way, because it was really close to the ureter ostium of both ureter. So what was done was realize a debridement and a suture and a Foley catheter and irrigation, a three-way Foley catheter. They told me that they looked to the rectum. It was no rectal injuries and no other lesions in the abdomen. I don't know if somebody wants to ask something.
I'd like to ask you,
Yeah.
what do you find when you open the abdomen? You did an exploratory laparotomy, longitudinal
Yeah.
incision. You see the pelvis. What did you see in the pelvis?
What it was not me who did the first one. It was like an open laparotomy. The
Okay.
famous, as we joke here in Brazil, the transamazonic, like it's a full one. So it
Yeah.
was a complete view of the abdomen. What we saw, what they said, there was some blood in the pelvis. So,
Mm-hmm.
but they could not see really the bladder. It was really hard. So they opened in the domos, in the
So
superior part of the bladder, so they
mm-hmm.
could see from inside the bladder
Exactly.
injury, and that's why they told that it was really close from the ureteres, the osteons of the both ureteres. They
So
look also.
there was
Mm,
not an intraperitoneal
no,
row. No,
no,
it was
it was the impression, it was like it was in the posterior part of the bladder,
okay.
so it was not
Lateral
anterior. Yeah,
from
lateral. Yeah,
left to
it's
right.
across. Yeah,
Okay.
from left to right, it was this way. And they looked at this moment, they looked to the rectum, and it was okay also, with no lesion at the
Okay.
first moment. And they put a Foley catheter. Then this was done inside the OT by the surgical team with a 3-way, so they can do the irrigation, because there was a lot of blood, a lot of clot. So
For
that's
me to
why.
be clear, just to be clear. So
Mm.
they open the dome of the
Yeah,
bladder, they identify the ureters, and they suture the holes in the tears in
yeah.
the bladder,
It
and
was.
then they
They
close
found.
it.
Yeah,
Okay.
they closed it exactly,
Okay.
because it was a male, so the pelvis was sometimes it's hard. It was a thin patient. This is
Okay.
one thing good, but at the pelvis a little bit more closed. So to see really the lesion, they decide to open and look from the inside, because
Okay. It's a good
really from
approach.
down.
There's a
Let's
request to see the X-ray again in the chat, if possible.
Yeah, let me see
yeah,
if I can do it.
let's listen, Dr. Untrach, Dr. Cassin,
This
about
one.
this approach. Would you do the same, Dr. Untrach?
I might. I defer to the people who are there. So I gather that a Foley catheter was not placed before going to the OR. Is that because there was blood in the urine, or is that correct?
Yeah, yeah, it was already
Okay.
blood in the urine, so this was the
Yeah,
decision.
exactly. You say positive, so there was blood in Morrison's pouch and free blood in the peritoneal cavity, right? You found
Yeah,
that? And
but much more in the pelvis, like from the superior abdomen, it was
yeah.
completely clear. Yeah,
Okay, so it sounds like it wasn't coming from the bladder, so or maybe it was, if it was just the edges of the bullet track were bleeding. But so I think that's reasonable. You wouldn't have opened up the bladder and searched very carefully unless the patient were hemodynamically stable. So initially he had a blood pressure of 85, although he wasn't tachycardic. In the OR at this point, I gather that after the plasma and the blood and the whatever fluid he got, that he was hemodynamically stable, normal at that point. Correct?
he was. Yeah, he was
Yeah.
stable at like it is the 19. This is maybe it's but we're gonna see for
Yes.
the days. He's
Right.
19,
So yeah.
young and strong, and
Yeah. So yeah, and I think given that they were looking very carefully at the bladder, looking at the trigone and the
yeah,
ureal orifices, that at this point they had done a careful exploration, ruled out any major arterial injury, which you'd be concerned about based on that trajectory, and then also and you said there were no rectal injuries, so they looked carefully for that. No pre-sacral injuries, because in this case, I probably would have also explored the pre-sacral space, unless there was a hematoma that actually dissected it for you. But I would have done a careful exploration along with the exploring the bladder, and then repair the injuries as you did. I probably wouldn't leave a suprapubic catheter because you can just insert a Foley catheter at the end of the case. But I think it's reasonable. Obviously, I defer to the people who are there because very good surgeons, and working in a situation with limited resources, you have to be very good clinically because you don't have a lot of the high technology to help bail you out if you miss something.
They put that they didn't see any vascular injury. They explored both the pelvis. There is no hematoma. That was the point. It was really the impression. It was really that was coming from the bladder. So
there is a question in the chat. Judy Lice asked us, under such circumstances, what are the main principles and procedural sequence for damage control operation? Can you answer that?
I'm pretty sure that this, I can tell you that he was after the event, it was like, I think it was 2 units of blood and 2 units of plasma, and then the patient was okay. Like the blood pressure was normal, no more sign. It was not a damage control at this moment. Not at all. He was pretty okay. It was done. He was urinating in the end of the surgery. So he was extubated in the end of the surgery. He was pretty much okay.
Okay. So this first operation was without any. Did they use methylene blue to see what the ureters were intact?
No, because it's something that we don't normally. So
I would use if we really if we are in doubt about the tract. But here you don't have a doubt because you have the tear above the trigon, like Maria Fernanda said. Because certainly for you to suture it, you have to cannulate the ureter. I wouldn't do a suture without putting a little catheter inside the ureter. I'm not sure, Maria Fernanda. How do you think about this?
Yeah, probably this is, but they are talking maybe that we're gonna just put some blue like putting and to see if there is a fistula or something, or lesion in one of the ureters. I pretty much, that's the point. Like they look from inside the bladder, and they say it's okay, it's closed. We need to take care because again, it's gunshot. I think this is the major issue is gunshot. So we have the first lesion that is the passing, and then we have like maybe the second, third, and the fourth. Maybe from you're gonna see we have more days because
it's
not gonna end here because
I'm seeing you're kind of anxious to
we know we have
go on. Let's do it.
We know this is the point. Like we know that there is such more because I'm here to talk about this strange case again. So so the patient was but let me see. So the first postoperatorium was okay, vital signs was okay. It's still some blood in the urinary bag. It was, but no signs of any clots or any major bleeding. And I'm not seeing what I wrote here. So continuous bleeding. We kept him in the recovery room for observation because we didn't have an ICU at that moment, but he was okay for more 12 hours. At this time, we didn't give any food because we still like a little bit concerned about how the things were going for the next hours, because this is the gunshot was like 80-90 p.m. So this is like it was 12 hours after the laparotomy. So and then so the second he was stable. Still just a small amount of urinary bleeding, probably from old. We suspended the irrigation because he was like to avoid the clot. So we just put in like
I'd
saline.
ask you exactly this. Is it common for you? You put this for penetrating trauma too? When we have a bladder injury, you don't usually wash the bladder. I would ask you, Dr. Untrach and Dr. Kasim, would you do that as a routine thing after a bladder injury?
Go ahead, Dr. Kasim, you go first.
Okay.
It depends on your comfortability of the repair. If you have done a good repair of the posterior part of the bladder which was injured, I usually do not do a three-way irrigation, and I merely would put a Foley catheter and get out. But before I do that, I want to make sure that I did not compromise the ureteric orifice. And like you, Mr. Chairman, I would like to cannulate both the ureters with retrograde catheter or whatever catheter available, and make sure they are patent and they are open, and I did not compromise anything after I have almost finished closing the so-called lacerated bladder from the bullet wound. And then I would either leave it in or take it out, whichever is convenient. If I'm in rush for time, I would just leave it in because I'm pretty sure that I can go and take this catheter out transurethral after when the patient is recovered. And that gives me a peace of mind that the ureters are okay. And one thing that I can eliminate from further problem down the road. The answer to your question is no, I don't do irrigation. Thank you.
Thank you. Maria Fernanda, go ahead.
Go. So this was the second day. It was stable, so we stopped the irrigation. It was already clean urine. We started oral intake with good acceptance. The stool was positive without blood. And then the third day, rectal bleeding, one episode and one episode of fever also. So they did a rectal exam with no blood at the glove. The vital signs was okay, no tachycardia, exception for the fever. Blood pressure, no tachycardic, not any other kind of dysfunction. Then we asked for for some labs, like hemoglobin was 8.3. The white blood count was this was the third day, so it's still like some it's a little bit elevated, but it was okay. And then we decided to do a CT, abdominal CT at this moment. I have the image if somebody, and decided also started to antibiotics for our profile here. It's amoxicillin is pretty much okay. The bacteria from here, it's pretty much okay from even from third day here.
Maria Fernanda, there's another question. Jaime Valikilian, sigmoidoscopy available? Would you consider a sigmoidoscopy? It was not available, or you wouldn't consider it?
Me myself, I would not consider. To be honest, I was like when you look through the entrance and what the bullet is and what pressed by, to be honest, I was expecting this. And I don't think it's for this moment. Yeah.
Okay, let's
so flip. Yeah. So we have one CT. Yeah.
Can I make a suggestion? I would like to chime in. In my opinion, and I've been doing this for over 20 years, and there is no such thing as single organ injury in a bullet wound, unless you are extremely lucky. If Jesus is with you, you thank Jesus that he did not get anything else but the bladder, and that rarely occurs. And in a case like this, if the bladder is injured, especially in the posterior wall, like you say that it did, I would be extremely suspicious that the rectum has been injured, no matter what anybody says. And I want to make sure that I know absolutely clear that there is no injury to the rectum Either I will do a proctoscopy or I'll do a sigmoidoscopy on the table there to verify or deny rectal injury. Then I can go to bed in peace. There is no such thing as only one organ injured through a gunshot wound, unless you are extremely lucky that night. And it does happen, but it is very, very rare. So now that we are looking at fever and white cell count, then I'll become extremely suspicious that there is more injury that I missed. Dr. Untrak.
Yes, so a question and then a comment. So do you have the hematocrit immediately post-op or the first post-op day? Is that a hemoglobin of 8.3? Is that a big drop?
No, it was pretty much the same. It was, I think it was
Okay.
9.
Right.
Yeah, no, it's pretty much, yeah.
Right.
It was no major bleeding.
Yeah, obviously in this setting, the third post-op day, so it's not late, but not totally early. But you would assume that maybe you missed an injury, a bowel injury, because he's febrile and has a leukocytosis, and that's reasonable. And you might have missed something, but that's not a that can happen. You still did a thorough exploration, and you were comfortable, and you were probably in disbelief that it was only the dome of the bladder injured, but you couldn't find anything. That's fine. You followed him. And I think you would have done what I would have done. Now, I don't know what your resources are. If you have ultrasound, I would use that daily to see if there's any damage to the ureters through hydronephrosis on either side, to be sure both kidneys are functioning, that the bladder is adequately emptying. You can see that with ultrasound instead of irrigation, but if you don't have ultrasound irrigation, I think it's fine. It worked for you. And one comment, I don't know, amoxicillin clavulanic acid, that's oral. So the third post.
No, we have IV. We have IV.
Oh, you have that intravenously?
Yeah.
Okay. So,
yeah.
Right. Okay. So you did get intravenous. Okay.
Yeah.
Yeah. There you go. Okay.
So that's the point. We have IV. It's
yeah.
Or even if it's not, we can use ampicillin also. We have both IV here. Yeah.
Okay. Yes.
So so basically this was as I told you, it was the third day. So let me I will look now for the first CT, and it's gonna be written for else. Find the first CT. So you are seeing this?
Yes, pneumoperitoneum up there, both kidneys.
It was pretty much just like
colon little distended.
So we have here like the bladder, here.
Gastroperitoneal area on the right side.
Exactly. So
let me ask you, how many rows, how many rows you had in the
it was only one. That's so.
Dr. Kassim, may I add that if you don't have just one organ, you don't have just one row, one hole.
But it was in the bladder. They look entrance and exit. It was like
so
2
there
holes.
are 2.
That's why,
Yeah. Again, there is no such thing as one hole.
So that point was probably, and so we have also here a fracture and.
So, I'm seeing it.
Yeah.
There is another question in the chat. They were asking if there was rectal bleeding at the arrival, Maria Fernanda. Do you remember?
Yes,
it's written, but from the surgical point at exam,
they
from
repeated
the surgical,
the
it was
exam,
not.
they found nothing. Okay.
They found nothing. So based on this, the patient was stable. We pretty much assumed that he had a rectal, extraperitoneal rectal injury.
Exactly. You assume at that point. You assuming.
Yeah. So, but the patient was he was pretty much okay. So let's go from the first. And the fourth was okay. Some diarrhea now and mucus, and the nurse told us that maybe it was like urine and in the diapers. we are not so sure about this. So we're still like taking a look, and I have to say, in a really bad thing, but this was weekend, and this is something that sometimes happens, probably in all over the world, that we don't change anything that it was going. So the 5th and the 2nd, it was okay, but it was we changed antibiotics, and he had this rectal bleeding and no more rectal bleeding at all. It was done. Okay, he was stable, and then in the 7th day, 2 more episodes now of leaving blood, like hematochezia, and then it was one day that they decided to put it in the OT to do a rectal exam in the lithotomy position with a speculum and everything, and planned that maybe if they saw, they put a colostomy. They didn't see anything at this exam. They just
but they probably did not open the retroperitoneum, did they?
No, they opened. They look at from outside. They put him in the lithotomy position. They put a speculum, and they took and they take a look, and
so from and they found no rectal
not at
injury.
all. No rectal injury, no hole, nothing. They just decide to do a blood transfusion, 1 unit, because the HB now it was 7.5. So, and also now they asked angio CT.
Did you think about cystography, cysto CT, for example, to try to understand if there is a fistula between the rectum and the bladder?
It was probably it was that point. We probably thought about this, and that's why at this moment we are talking about like putting a colostomy and maybe taking another look and reopen and all of this. But then but the problem is that he was bleeding, like it was quite uncommon that from where it was bleeding. It was not supposed to have huge major bleeding from the pelvis like this. So
he was bleeding from the rectum, so there are kind of hematochezia.
Yeah. The point was the way the blood was leaving the body is from the rectum. He was no other sign in the bladder. It was the urine was clear with no irrigation, like it was already done. And this was the circumstances that's what we had.
Do you have angio in your hospital? Angiography and embolization?
No, we don't. This is something also that this is something that happened when I saw the CT.
Okay, let's ask Dr. Untrash, Dr. Kasim, any ideas here?
Yeah, well, there are hints from what Dr. Detanico was saying that, first you think, you said that there would look like urine coming out through diarrhea, so you worry about a rectovesical fistula, but you saw the bladder from the inside, and if you would have seen any major connection, and and then you say now the urine is clear. If there's still concern, I would just inject some gastrografin into the bladder, and then take a pelvic film, and then see if you have contrast going to the rectum. That's an easy thing to do, but it sounds like you ruled that out, and there's more of a external iliac to rectal, an arteriorectal fistula, that the patient's bleeding from a traumatic fistula, based on, you said you did angio CT, I think that's an excellent option, and if you're really in an austere environment where you don't have CT, then you're stuck with exploring the patient based on that CT that you showed. there's a lot of air in the soft tissues, especially on the right side, a lot of density.
Mm-hmm.
And, I think the problem is there. So, you need to explore that area either through the laparotomy or through a retroperitoneal incision, like a renal transplant incision, to look at the iliac fossa and totally explore that area. I think that's where the answer is going to be, right there, and you'd find the source of the problem.
So you do another incision.
Just one thing. Yeah. They put the somebody asked about the blue methylene. So they put on the bladder also, and there is nothing coming from the they
rectum.
transform the urine in blue. There's nothing coming from the rectum. They even do the rectal exam. So this is what we did kind of this at one point. So we did another CT. Let's go for, let me see. So what we have here is this one.
There.
So I just took from the, so we still have the bullet, but we have here, probably. It was a really bad quality, to be honest. I was really upset because it was not good as they can. And as we know, they sometimes they need to, even if it's a CT, they need to be done right in a good way that we could see better with good reconstruction. So what we thought that he maybe have a pseudoaneurysm here on this region. Yeah. And it was bleeding, yeah, from inside the rectum. And then again, and this is how we have a lot of CTs, we have a lot of things, but we don't have, for example, let me just put this one again.
Angel.
Yeah, angel, and we don't have like, no, hold on. No. Let me see this one. So we don't have the angel. So, and it was like this, it was me calling the guys from the radiology, because in the other, we are a group of hospitals, so it's not inside my hospital, but it's in another one. But it's not all the days to have this available. So it was me calling, talking to the guy to see. I talk also with the vascular team, also talked to him, saw the images. We didn't have the official results from the radiology at this time, but we saw that it's something wrong. And again, we are like, was Thursday, and I was like, okay, I'm gonna give one shot for the radiology. If it's not, I talked to my friend that is a vascular surgeon, and I did, okay, let's do again, because we did once the enemy joke that we're gonna do the Adenauer technique, carrera nose, because he saw this, my vascular friend, he saw one presentation of Adenauer, and what we decided that, as we don't have, like, we're gonna be Friday, it's not gonna be done on Saturday and Sunday, this guy is bleeding, and we're gonna have this again. So we decided to put in the OT, do an open, this was the other day, an open embolization. And this is what I joke, because we have heard, of course, once I heard of Dr. Coimbra doing something like this, but here in Brazil, we have this vascular surgeon that he did this presentation, and we joke. Even I talked to him like, we're gonna do the Adenauer maneuver, and we're gonna do the technique. And at this time, what we did, let me put, because I have also some videos. Let me see, not this one. So we took gel for, and basically we did cut, put one syringe, another, put some saline. So we have this, and it says it's me now. And some resident who did the video, now you can see that it's not in the regular position, or maybe some academic, I'm not so sure. And
this happens.
This happens a lot. So we have this, and I have also some pictures that we put, because what we decided is this way. So we have this on the left side. We as you can see, there is no major hematoma also. So we dissecated the iliac. We're pretty sure that we are the external was okay. So we were really inside the pelvis, so that it was the hypogastric. So we just put a clamp. It was here. We put a clamp here, and then we did this with the syringe and alpha, and then we took it's Abocat, I think so. A 14, it was a huge one, and then we did the injection on here, on the left side.
So you isolate the common, external, internal, and you clamp.
Exactly.
You clamp
We
external
clamp
and
proximal,
inject.
and proximal, just to don't anything comes from maybe goes from the external one.
Okay.
It's something that we did, because it was really a minor rectal artery, but it was like causing us bleeding.
Okay.
And then we have problems. So now the patient was still having some fever. I was in that, and then they saw that there is maybe an abscess between in the pelvis, like in the retroperitoneal space, the extraperitoneal space, and you are like this. Now we are open. Let's open, not open. We already decided that we're going to put a loop colostomy on the.
Let me
okay.
just let me ask you. This abscess was noted in the same operative procedure. You did this
It was in the
embolization?
CT.
Okay.
Yeah, it was in the CT, and we are like, okay, now we have the patient open. Are we going to get this in this?
Are you going to drain from the same incision of these? Exactly. So we are there. Did you use something like this before, Dr. Nutrash? Open embolization for pelvic fractures, or in this case for pelvic fractures, I've done some, but this for a pelvic pseudoaneurysm was very, very intelligent, Maria Fernanda. Congratulations.
Yeah,
this is the second one that I did, because I did again for a gunshot. Yeah.
Even back when I trained in the mid 1980s, toward the end of my training, we had angioembolization, and we would use that for rectal bleeding, that to identify the source of bleeding, embolize it. But I've never done this. We did a lot of open angiography procedures when doing vascular operations, because that's the way it was done back then, but never, we didn't put stents in. We would do embolectomies, and we wouldn't embolize through an open procedure. But and in this case, so based on the CT that you did, it looked like there was extravasation of the intravenous contrast along the left lateral pelvic wall outside the rectum, right? Yeah.
Yes.
Okay.
Yeah.
And also abscess more on the right than the left. So apparently this worked for you. So kudos. But if I were in a situation where you had your facilities and limited, not remote, you still have the CT and can do all that. And can they do CT guided drainage at your hospital? Intervention?
Again, it's the same. It's both the same radiology who could not do the embolization. So this was my point, and I was having like this patient that it was. He was not bad, but because we have like these 2 points, like we have the bleeding, and we have the infection, and we have and this is what I was thinking at this first moment. Are we going to get into this mass on the left mass? Okay, let's do it. I think it was today. But to be honest, on the right side, and like, are we going to get in or just like put a colostomy here? And and sometimes it's just like you get out, you just don't get. I was thinking like gonna get in trouble or not. Was my point at that moment.
Right. Exactly.
And
Go ahead, finish up.
And this was the point. So what was my decision? That I was, just to tell you, I got in trouble. So this my decision was because he was not controlled from the septic, the sepsis. It was not controlled. So as I was with the patient open, it was like in front of me. It was, in theory, it was the heteroperitoneal space. It was open on the first surgery. That's what they told me. What I saw, it was not, because open, then I needed to open. Yeah.
Okay. So if I can just finish the comment. So in my situation, I've never done that. So that's where you inject the gel foam. That's the Adenauer procedure. Is that it? I'm not familiar with what happened. So in a case like this, where you're going back to the OR now, is it the second or third time return, first or second time? Yes, second time. I would do what I would know works. So I've never done that. So it wouldn't, I can't say that it would work for me. I wouldn't do something for the first time. In your case, I think if it's worked for you, fine. What I would do in that case is to, mobilize the rectum as if I'm going to do, do a low anterior resection as if for a colon tumor. Mobilize the rectum so you would have both sides mobilized, the presacral space, and then free up the rectum anteriorly, and then divide the middle hemorrhoidal vessels, because that seems to be where the bleeding is coming from. You can do that on one side with no problem, and then probably you would get into the abscess if there's pus coming from one or both sides. Drain that, and then you have a chance to look at really examine the rectum. If there's no stool leaking, no enteric contents, you don't even have to do a colostomy. If you're worried, a colostomy is certainly reasonable, but may not be necessary. You might be able to avoid it, but still, in this case, that's what I would have done, because that I know would work for me, because that's where the money is, that's where the problem is, and I know that would work. So I would go straight to that. I wouldn't have done this Adenauer procedure, only because I don't have, it's not a time for me to experiment with something new, even if it were suggested to me by someone else who looked in. But anyway.
Thank you.
So as I told, this was the second case. The first one, it was really also, again, a gunshot, and it was like a bleeding, that kind of pelvic bleeding that you just like, you put the compress and then you take it, and then the field just do like this with the blood. So we did once, and because the first surgeon who did for this other case, he ligate the epigastric and didn't work. And then, we asked it, we took one time and the second, and so we asked it for the vascular also from the other hospital to do the intervention. They said that there is no indication, and then we decided, we're gonna do it here, and we did that, this open embolization. And from this patient, it was impressive, because it was like we did, and as we have this, we just could see that it was not bleeding at all. But this one, the first one, it was not so. This one that I was thinking in bring here, but it was not so, with photos and everything. It was not so clear.
Let me ask you: did you ligate the internal iliac after embolizing or not? Because this is a difference in Adenauer's procedure, Dr. Untrach. This method was described many years ago for pelvic fractures that do not respond to fixation and packing, and we learned it from our friend Dr. Coimbra when he was in Santa Casa, and the papers that describe this method, it was discussed, and there was this the situation, and we are used to ligate the internal iliac and then inject. And the Adenauer procedure, it's our friend. We are kind of teasing because I'm kind of, I got a print screen that I'm sending to him, say, wow, now you have a procedure, you're a famous guy. It's Adenauer's procedure. He said we should not ligate the internal iliac because the flow of the blood flow will embolize the particles for it. So you ligate, you don't have the same results, he says. He's a very, very, he had presented many cases here in the Pan American Trauma Society.
Yeah.
Dr.
So
Cassim,
basically,
let me
the
ask you,
only
Dr.
difference.
Cassim. Dr. Cassim, experienced trauma surgeon.
He's in the shadow now.
Yeah,
He's just looking at us. What these Brazilian crazy people are doing.
No.
Well, this is a very difficult case, and you have to do what you feel comfortable. And I am with Dr. Untrak. I don't like to do experimental stuff when I'm in trouble. Mm-hmm. And like I said, there is no such thing as single organ injury in a bullet wound. Always be suspicious. There will be a second organ involved or third organ involved, and missing an organ injury will pay a price like you're doing right now. You know, when you have a posterior wall of the bladder injury, you need to be suspicious of the rectal injury, and you are mandated to mobilize the rectal stump and have a look at it carefully to see if needs to be repaired or stapled and a protective colostomy created, because those are the normal things that we used to do. But I know the heroic young surgeons now, they don't believe in any of that. They just go and do a repair and don't create a colostomy or anything like that. And then they call the radiologist to drain if there is an abscess and get away with it. I think this problem is kind of universal. If you have an injury on a Thursday, you do surgery on a Friday, you have to wait till Monday for the radiologist to do anything for you.
Yeah.
And the radiologists are not surgeons. They work Monday to Friday and they are off for the weekend. And especially in small hospital like you have. So be aware of that when you do surgery on a Thursday, make sure you do it once and for all, solve the problem so you don't have to go back. I personally have not done Dr. Adenauer procedure. I'm not very familiar with it, but it is an educational thing for me to learn. There is such a thing called Adenauer procedure, championed by Dr. Raul Coimbra, who is my hero anyhow. And I have learned a lot from Dr. Coimbra listening to his lectures. And if he said that this thing works, and I trust him, but I certainly will not do it. Thank you.
Okay, I'm trying to.
I will.
I have the paper, the original paper here, and I'll try to put it in the chat, but I'm not, getting this. Maria Fernanda, can you go on? We have 5 minutes left. 5 minutes left.
So
let's finish the case.
This is something that I would like to present. Was my point, that it's why I told it's a different vascular approach from this. So, but as I told you, I got in trouble, not at the left side. I got in trouble in the right side. So I decided to open and to see if there was an abscess and how it was. So what I found, it was and down out. Was the right side. So what we have, it's a hiatal injury and a bladder also. It was open. So we decided to suture again. And this is, I can tell you, was my mistake at this moment. And I'm gonna ask why. I didn't go through the ureter, for the right ureter, and this was my mistake. I'm gonna complete in the end, because I should have probably put a stent at this moment. I don't know if it's double J or uretero stent, because I saw both of them in the Porter Lake. And what we did the suture, we debride the rectum and did just the suture, but we put a loop colostomy on the sigmoid. And then we did another bladder suture, and we changed the Foley catheter. We put a silicone one because it was a latex one. So we decided because probably he's gonna stay for a long time. And the 10th and the 11 PO from the first laparotomy was okay. No rectal bleeding. It was starting to take oral intake, and the colostomy was not working. And the first and the second. So in the third day, he was not okay. So we did another. They asked for another CT, and they opened. And then the ureter, the right ureters in the bladder was necrotic, so they did ureterostomy. And with the double G, or what I saw, it was ureter stent. I don't know how to say this in English, to be honest. And also we started, because he was like not eating at all, we decided to start the total parenteral nutrition also with the offer of the oral intake, but as long as he was not accepting, because laparotomy and another laparotomy. And then this was okay. And more 2 days after, he had another intervention. Now this is the third one, because he was in abdominal pain, also tachycardia and fever. And in the ureter, it was open, was the ureter, and was the right ureter. So what my colleague did, they put a cystostomy. He put it from the outside and put a Penrose also, but the other of the abdomen was pretty much okay. And after 39 days of the first laparotomy, he was discharged, okay, walking, talking, eating, with a ureterostomy and a loop colostomy and a closed abdomen. That is, for us, it was really because we are starting getting worried about not being able to close the abdomen anymore. And the plan is to do a new angio CT in 2 months. And already we asked for the urology to do the ureter reconstruction. And was the patient. And this is, you can do this picture to him and talk to him that I made the Adenauer maneuver. And this is Adenauer.
Great. What a case. What a case. Well,
and this is the first
congratulations.
one I can tell you that the patient's alive and good at home eating, and no,
What
it's
a
very
case.
much okay.
Congratulations, Maria Fernanda. Thank you for presenting this, everything. I learned a lot with your case again. Well, I just put the reference of the Sauer-Racker work that was from 1987 about this technique for life-threatening pelvic hemorrhage in the chat, if anyone gonna see the original paper. But I'd like to hear the final words of Dr. Untrach, Dr. Kassim, before finalizing the meeting. Dr. Untrach.
Yeah, it sounds like a really great case, well done. So that Adenauer procedure, that means you should be able to use it for severe pelvic bleeding bilaterally, and then not have Lariche syndrome that you may, if you ligate both internal iliacs. Is that right? That's the advantage, that you can use it.
He did not. Yeah, I saw him presenting this for pelvic hemorrhage and bilaterally, and not ligating the hypogastric artery. That what I saw. Fernanda made something different. I would say Fernanda added a new procedure, the Detanico procedure on Adenauer's procedure, so a Detanic modification.
But no ischemic symptoms post-op then, right? You don't get the claudication, whatever. That's good. That's the first I'm hearing of it, and you used it very well. And if I understand correctly, the patient had a traumatic rectovesical fistula on the right, without drainage into the extraperitoneal space. Did he have an abscess there?
When I that's what I said. Like when I got it into the right trouble, there was an abscess. Yes.
Abscess. Okay.
So yeah,
very
it was
clean
like
in the OR.
clean it and suture. Yeah.
So not just.
But
not
this
just,
is something.
Go ahead.
Sorry, this is like I can like talking, like looking from back, from the from nowadays from the back. I can tell you that something that I should have done at that second intervention was maybe putting a uretary stent at a double G, because maybe even if it's oriented, it should not be fistulated. Maybe I don't know. I was not pretty sure about this.
Yeah, I think the thing with the ureter, it might not have been a surgical damage to the ureter, maybe just the original trauma, if it was near the fistula.
Yeah.
But what the fistula was leaking, so there was a fistula that had formed between the rectum and the bladder, and then that was leaking, or or maybe you don't know.
No, it was a hole. It was because when I go from the right side, I saw the Foley catheter, the balloon, and I saw the rectum also, the mucosas. So that's why it was like okay,
not really
suture and
it was
catheter.
basically a cystotomy and a rectotomy that was leaking. That leaked.
But this was in the third one. When they put a cystostomy, it was always by the Foley catheter. Just in the last one that it was a cystostomy. After before this, no.
Yeah, the infection didn't allow. Probably the infection didn't allow it to glue.
To heal. Yeah.
Yeah. Right. But I think you could see that on the very first CT scan. The problem is that bullet. There was so much scatter that it obscured, and I think that's where the money was. I mean, I would have done as I mentioned, because I don't know about the Adenauer procedure. I would have ligated the middle hemorrhoidals on the left side, explored the right side, and about the ureter. That's whether it's something that wouldn't have happened had you put a stent there. I don't know about that, but still, it's part. You took care of it, and the patient's going to save both kidneys, and I think it's well done. Well done. And that procedure, that's something new. I learned about it. I still wouldn't try it if I were in the OR because I'm too old for that. And I know what I would do. And probably if I were in a remote location, I wouldn't have the gel foam, but it's really very well done. Worked really beautifully for you.
Yeah. Let me, I'm just, I wouldn't do comments here, but I'd like to ask Fernanda, if you were the surgeon in the first operation, would you have opened the retroperitoneum and considered looking for the injury in the rectum? I mean, we learn in books that we try also to put a viable graft of momentum between this kind of injuries in rectum and bladder, just exactly to avoid this kind of injury. Would it be possible or not?
I think the patient was stable. I would have it open and to see, take a better look. And even if I could, because probably they could not see even from the suture from
the bladder, of course.
The
that
bladder,
was the problem.
First one,
they didn't open.
And also
they didn't open the retroperitoneum.
Yeah,
it's a
no,
difficult
it was not
field
open
because it's a very low track. I understand that, but if I face a situation in which there is blood in the rectum, well, I'll have to pay to see what happened.
And
Dr. Kassim.
And this is and just one point, it was a thin patient, it was an obese, that it was much more complicated. Maybe I will not not contaminate, but like putting something inside the abdomen cavity, because when it's down there. You put some like apart, but this one, I would have opened at the first.
Dr. Kassim.
You know what they say, when you're working in the biliary area, it's a tiger country. I look at the pelvis as a crocodile country, because usually you miss something, then you start crying as a surgeon. Oh, I should have done that. I should have done this. I think when you work in this particular area where there's bladder, ureter, rectum, perhaps even small bowel sometimes, there is no such thing as one organ injury. Please take that for sure. That's what my teacher taught me. He said,
Yeah.
when you have a one organ injury, look for the other. When you have a single hole, look for the second hole.
Yeah,
And
exactly.
that is the lesson that I learned when I was young. So I certainly would have repaired the bladder and perhaps stented both the ureters to make sure that I did not do anything stupid, which usually happens in the middle of the night. And I would also, at the same time, open up the retroperitoneum, mobilize the rectum, have a good look at it, because the first look is the best look. The first time
Yeah.
you repair something, it usually will
Exactly.
work very well. But when you go back after it gets contaminated with abscess formation, then it is not fun at all. It becomes a very long, drawn out affair. But all in all, I must say, Dr. Maria, you did a fabulous job. You didn't give up.
Thank you.
You went after this and saved the patient's life, which is the most important thing. And also, you taught me something today that I was not aware of. I will not do it, but I will keep that in my computer.
Yeah, that's.
Thank you.
Yeah.
Thank you very much, Dr. Cassim, Dr. Antrash. Well, we all have learned so much today. Thank you very much, Dr. Maria Detanico, for presenting this. I used the words of Judy Lai in the chat. She said, I learned a lot from this case. Thank you for share all the concepts focused on. Thank you very much for the presence of everybody. It was very educative for all of us, and see you around. See you next
See you.
Pan
See you next.
Americans Bite presentation. Thank you all.
Thank you. Bye bye.
Bye. Congrats.